So Dr. Patel, as most of you know, is the Joe D. Morris Professor of Cardiac Surgery here at the University of Michigan. He's the section head of adult cardiac surgery. He's giving grand rounds this morning for the Department of Cardiac Surgery. His lecture is titled Physics, Blood Flow, Aorta, and the Real Why. Thank you, Dr. Patel, for speaking with us today.
Curtis, thank you very much, and good morning to everybody. Let me just make sure I can get this puppy down here. I'm going to start by just maybe sharing with you that when I operated on a college professor several years ago, he had been the longest tenured professor or president of a public university in the state that he came from. It wasn't ours, but he made one comment to me that I've thought about for some time, and he said, there are two public institutions in this country that actually set the standard. One was Cal Berkeley, and the other was the University of Michigan. And he said, of those two, it was the University of Michigan that really mattered. And I think, the purpose, hopefully, of today is to highlight what a lot of our colleagues in this cardiovascular center are doing, and some of the really groundbreaking work that they do on a daily basis. And for me to just highlight a little bit of what they let me kind of be involved in. And then hopefully along the way, what I hope you will do is actually learn a little bit about me. So, here's my CV. And, when I came to Michigan in the year 2000 as a thoracic fellow, my CV was pretty tiny here. And I've been here now for 22 years, and the CV has grown, and it's become, quite expensive, as you might expect. But this is what I think, if I were to say I'd be most proud of, that would be it. These are my parents. These are my mentors, my sponsors, my coaches, and most importantly, really my moral compass. And my mom passed away when I took my current seat, but my dad's still around and providing tons and tons of advice. These are my life partners, my brother Katul and my wife Hina. And we're standing here in front of a very famous lobster shack that we had the privilege of visiting last fall. And if you were to ask me who the greatest cardiac surgeon I ever met was, I would say it was Dr. Vincent Gott. And Dr. Gott, who I got to know in medical school, was an early pioneer in cardiac surgery. But I don't think he was the greatest cardiac surgeon because of that fact, or because of all these seminal contributions he made to our specialty. But it was really that despite all those seminal contributions, he remained, to me, probably one of the most authentic and humble people who I've ever met. And I think of him often. He passed away last year due to COVID. But he is a person who I believe represents the best in our specialty. And here he is. He came to my graduation in medical school to meet my parents after I'd gotten to know him very, very well. So I think the first thing we got to do is we got to provide some acknowledgements. And these are benefactors, not just for the research that I'm going to present here, but also partners of the section of adult cardiac surgery, which I have the privilege of representing as well. And some of these folks have been with us. Some of them I've taken care of and had the privilege to take care of, but they've been with us for some time now. And I just want to acknowledge them up front. So the title of my talk is Physics, the Blood Flow, Aorta, and the Real Why. And I hope by the end of it, at least many of you will be still awake this early in the morning. So these are my disclosures that I have to state up front. So we're going to start by the what, and I'm going to describe some of the fundamentals and really two scenarios to perhaps highlight this what. And I'll start by telling you that I'm an immigrant. This is the house that I grew up in East Africa, in Kenya, in the coastal city of Mombasa. You can see the two things that it's most famous for. One is the tusks that span Digo Road, which is a major artery in the city. These were built in honor of Queen Elizabeth's first trip, shortly after she became queen. And obviously the letter it spells is the big M. And the second is this this fort that was built on the coast of Kilindini Harbor, the natural harbor where Vasco da Gama landed as he made his way to India. And you can see that this fort, which is shaped like a man, you enter in the armpit of the right arm here. This fort was Fort Jesus. And And the prevailing story in Kenya when we left in 1979 was really two things. One was that the despot in the country right next to us, as it emerged from colonialism, was Idi Amin, and he had just been overthrown, which was a big story in that day. And the second was actually that of something we used to see almost every week, which is the concept of matatus. It was the Uber in 1970s Kenya, where you would have minivans, people would pile in, you'd have 16 people in the minivan, and it was almost every week or every other week that we'd hear about these things going on the roads and turning over and people getting hurt and so on and so forth. So those are the two big stories when we came to this country, and I was 11 at that time. And when we moved to this country, one of the things that I remember very early is my dad would tell us when we were driving around in Western Pennsylvania that it would be hard for matatus to tip over in the roads that we have, partly because of the engineering, where when you go around a curve, these roads were tilted. And to my surprise, several years later, I took a physics class that actually allowed us to compute some of these angles and velocities and all these things. And so this became, the impetus for my lifelong love for the most fundamental of all sciences. And when we think about physics, we think often about, Albert Einstein appropriately. And this gentleman, if you've ever read this book by Walter Isaacson, if you've not read this book, I would highly encourage it. One of the pioneers in this field. But when I got to college, I had the opportunity to learn about other people. So J. Willard Gibbs, who Einstein at the turn of the last century called the most prominent physicist and mathematician, who developed vector calculus, thermodynamics. And then these two people, Werner Heisenberg and Erwin Schrödinger, who developed the concepts of quantum mechanics. Erwin Schrödinger, incidentally, was the person in physics who turned his eyes to biology and delivered a set of very seminal lectures in the 1940s in Trinity College in Dublin, which were then penned in this book called What is Life? And in this, he spurred a number of physicists to really approach the field of biology and develop a whole new concept with this multidisciplinary approach and a field that we now call molecular biology. Two of his disciples, Watson and Crick. So when I got to college, I had the opportunity to take a class in statistical biophysics where the professor made a very interesting statement. He said the natural world can often be explained in terms of basic concepts of probability and a sound knowledge of statistical methods. Now, really, why do we care? We're like doctors here, and we take care of patients and so on. And the answer is pretty simple. When I go to clinic today with Mary Passo and with Amy Elliott, I'm going to see patients with aortic aneurysms. And when we operate on patients for aortic aneurysms, we're doing so because we're doing it to figure out whether the operation that we do is going to improve their life expectancy. We're not doing it to make them feel better. And essentially what we're doing in clinic is we're trying to figure out, is the probability of rupture and death greater than the probability of the complication from the intervention? And I'll focus a little bit on both sides of this inequality as we kind of meander through, what we would be thinking about in clinic. So the thing that we turn to naturally is dimension the most important factor? And this is a classic study from Yale, which highlighted that if you have an aneurysm that exceeds 6 centimeters in diameter, your annual risk for rupture, dissection, or aneurysm-related mortality is actually quite high. But what you notice along the way is that even those aneurysms that are small actually have this risk. And Linda Pape, who on behalf of the International Registry of Aortic Dissection, this is housed here at the University of Michigan, run by Kim Eagle, identified that of those patients that present to the hospital, fully half of them actually have mean aortic diameters that are less than, what we normally would recommend surgery for. So there must be something fundamentally different about having an aneurysm and having a dissection. How else could you explain this particular clinical scenario for a patient who had an 11-centimeter root and ascending aorta and who had only had a dissection in a mildly enlarged right subclavian artery? These things are not the same. So we look for other things in clinic. We look for anatomic markers such as bovine trunk, left vertebral off the arch, aberrant subclavian arteries, which we think may be signals for aortic dissection, the thing that we're trying to prevent. And then we look for other things like familial patterns, which may or may not be important. And these are listed here, which comprise really a minority of the patients who we will see. But curiously enough, this is not the whole story, because a recent study published in JACC followed a number of patients with these types of familial thoracic aneurysms, and we found wildly discrepant risks of aortic dissection, even up to 10 years. So it suggests that there is something a little bit fundamentally different between an aneurysm and a dissection. And I think we have some confusing phenotypes. This patient who presented with a bicuspid aortic valve and a 5.5 centimeter ascending aorta had an identical twin brother who had a 4 centimeter aorta and a normal valve, and a father with a slowly growing root and a normal valve. So there's clearly something, very, very different. And I think, in my mind, the way that I tie this together is a theory that was proposed by an engineer, the head of bioengineering at Yale. And I'm gonna highlight some of the aspects of what he has proposed. And he noticed that aneurysms can actually typically arise in the chest, the abdomen, or in the head. And when we look at commonalities between these two, we find that there's, from an ultrastructural standpoint, there's a loss of elastic fibers, functional smooth muscle cells, and remodeling of fibrillar collagens. But it's really only thoracic aortic aneurysms that typically dissect and have pooled accumulations of proteoglycans or glycosaminoglycans. And this is Jay Humphrey who penned this particular article. And I think one of the things that we have to remember is what the function of these particles is, or these molecules is. And these are essentially shock absorbers. We see these in knee joints as well. And they act to absorb some of the shock of what an aorta has to see. So if we go back to the normal aortic wall, the intim is really there to as a mechanism for homeostasis, releases factors that make fluid flow within the walls of the tubular structure nice and smooth. And the media really is comprised of these medial lamellar units. And this is where the dissection, we see the initiation of it. But it has these various compositions in the units. And the purpose of the media is really to bear the load in normal hemodynamics. And it comprises the majority of the wall. But the adventitia is really important for the extreme loading conditions. And it is these glycosaminoglycans which sit within the media of the wall. And there's a fundamental physical principle that is actually important, I think, in propagating a dissection that was proposed by Jay Humphreys. So when we look at the structure of these medial lamellar units, we notice that the glycosaminoglycans, these protein polysaccharides, are actually structured and evenly distributed throughout the aortic wall. But when we see these things pool, such as is shown in this particular slide here, as well as this histogram, what ends up happening is something that was described by J. Willard Gibbs, the picture that I showed earlier. And that is the Gibbs-Donnan Equilibrium. It is essentially a combination of driving things across an electrochemical gradient, as well as a concentration gradient. And these highly negative charged particles sit within the wall of the media. What they do is they essentially absorb sodium, and water follows sodium, results in local swelling and mechanical failure. All one needs to do is think about tissue paper that has a wet spot in the center, pull on the edges, and as a consequence, what we will often see is a tear right in that center where it is a little bit wet. Remind somebody of an aortic dissection where we often will sit there and sew something that looks like wet tissue paper. So I think, this is the real question. This is the view from my brother's place in New York City, by the way. But when we think about this, this probability, what is the probability of rupture and dissection? We think it could be something related to the size, but that's not the whole story. It could be related to the hemodynamics that the patients present with, but that's not the whole story. It could be related to the number of aneurysms. Obviously, if you have a couple of aneurysms, that probably likely increases the risk associated with it. It could be associated with some function of the biology, such as what I just described to you. And then it's probably related along the way according to the length. So if you have a very long aortic aneurysm, it is likely that the risk for pooling of glycosaminoglycans may be different along that length. And what it tells us is that the knowledge that we have of this probability that I'll see when I go to clinic today is still rudimentary at best. And if we look at this formula, one of the things that it reminds us often of, and is the real question, is, reminds us of the famous Drake equation that was proposed at the SETI conference, which suggests the probability of finding extraterrestrial communicating life in the Milky Way. So I think we got a lot to learn about this left side of the inequality as we navigate clinic today. So getting back to the original question, when we see the patient today, how are we going to know what to do? And maybe for a little bit, what we should do is focus on the right side of this probability inequality. So the typical determinants that we see when we go to national meetings and we see very famous people kind of getting up at the podium and talking about the outcomes after surgery is we notice that there are, things like age and comorbidities, other things such as volume outcomes relationships that were proposed here by Chad Hughes. But there are these obvious unknown factors, and it is these unknown factors which I think I'd like to focus a little bit on this morning. And in order to do so, perhaps one of the things we need to understand a little bit about is computational fluid dynamics. Now I got Alberto on the line here, so Alberto, you'll promise to correct all my inconsistencies in understanding. But these are really fundamentally based on what's called the Navier-Stokes equations, which really describe conservation of momentum and mass. And these are highly important equations that we have in engineering today and mathematics today, because they do things like model weather, ocean currents, and blood flow. And really, because this is a partial differential equation, we can't get analytic solutions for these things, such as, y equals mx plus b or y equals x squared plus c. You can't get it. So what we have to do is we have to actually solve these equations by what's called a numerical iterative process. And we do this to find the fluid flow from, initial baseline conditions. And in case anybody's interested, if you're able to sit there and solve this, the Clay Institute of Mathematics has suggested that you could perhaps, if you can prove a solution exists and is what's called smooth, you'll be granted with one of the 7 millennial problems with $1 million prize. So some of you may actually want to get to work on this particular component of academics. But I think we should probably focus first on basic terms. And we talk a little bit about stress, which is the force per unit area, the strain, which is the change in dimension as one applies stress, and then think about hemodynamics in this consequence. And hemodynamics in this setting is really defined as the interaction of pulsatility, which is the heart, kinetic energy, which is the flow of blood, and potential energy of the system, which is the blood pressure. We're all tightly regulated by peripheral resistances. It's really how we actually evolved from being a single cell to a multicellular organism to be able to get the nutrients that we really need to each of the vital organs that make us who we are. So when we think about these things, we ask, how does a surgeon do it? And in England, what we do is we find mates. And so I got a couple of mates here, Alberto and Nick, and you can see Alberto and I in the Dutch windmills here in the background. And Nick and I here, we were at the EX meeting in Portugal. This is a western tip of continental Europe behind us. But basically what my mates have is a lot of deep understanding and very, very fancy tools, such as is shown here. And it allows us to be able to answer some of those questions that we are presented with in clinic. So one may ask, how do we do something like patient-specific computational fluid dynamics? And the answer is pretty simple. We need some understanding of geometry, some understanding of pressures, which we get from a blood pressure cuff, and then we need some understanding of blood flow. And one option that we have and that we've used in some of the work that we've done has been the use of echo-derived cardiac outputs. Now, all these things have inherent weaknesses, biases, and all of these things. So there is nothing such as the truth, as I'm going to show you a little bit later, but these may point us towards the signal of truth. So in order to understand it better, the geometry part of it better, one needs to understand the term of vascular deformation mapping. Now, diameters, as we talked about, are actually quite insensitive measures of aortic growth. And it may be that surface and volume measures may be much more sensitive. Notice in this particular ellipse, the maximum aortic diameter really doesn't change, even though this elliptical pattern demonstrates eccentric growth. So if we apply this clinically, what we see is actually something a little bit different. But I think to do this, we need to understand what VDM actually is. It's the answer to the question, how does space stretch over time? So if we take this rectangle that's on the left and we apply a function to it, and we make it a different surface, how does that work? Well, it's pretty simple. There's something called a Jacobian tensor that we developed. It's basically a matrix, so an n by m row and column composition of partial derivatives of what's called a vector valued function. And when we take its determinant, essentially what it does is it gives us a ratio of the expansion or the contraction of this space. It's called the in this particular scenario, we were able to apply this clinically. And I have actually a model in my office I'm happy to show people. So the clinical scenario is a 23-year-old Jehovah's Witness patient who presented with Takayasu arteritis. And I was a bit reluctant to perform a arch operation in this particular patient because of her beliefs of not taking blood. So the question that I proposed was, is the arch stable? And when we look at the typical CT scans and measure 3 dimensions, what we see is we actually see that there's one area of rapid growth. And yet, when we apply VDM characteristics to it, we get a heat map. And we see that all these other sites, such as the proximal arch, the proximal descending thoracic aorta, or the mid-descending thoracic aorta, actually show some level of growth that's a little bit different. When we combine this with blood pressures, we actually may find answers to questions of biological instability. Here was a study done by Ignace, our Dutch student who graduated last Friday. And basically what he and my colleagues did was took an example of a map that was generated from vascular deformation mapping and placed pressures within it. So you take the model, you load it to diastolic pressure, you load it from diastolic to systolic pressure, and you generate a idea of how we get stress associated with this. And essentially what we found in this group of patients, and this was presented at the EACTS meeting, was that in this particular patient, and there are several others like this 40-year-old who had a history of Loeys-Dietz syndrome and prior type 2 DeBakey repair, what we found was that the area that corresponded to the highest growth by VDM had the highest level of stress, and actually was the site of the entry tear that we saw when this patient developed a subsequent dissection on follow-up. Something very unique that we combined, blood pressures and VDM with. So what happens if you add flow to this? And this was a study that was presented by another Dutch colleague, Diederik van Bakel. And in this particular story, this was patient number 4 in the branch thoracic endograft trial. And this was a 74-year-old woman who had a maternal family history of thoracic aortic rupture or aneurysm with rupture. And he was seen with the CT scan that is shown on the right. The first part of the scan suggests the time point 1, and the second point demonstrates that the descending aorta is much more rapidly growing and was the site that we felt was much more important to treat up front. So we took her to the operating room. We performed a branched zone 2 thoracic endograft. She was patient number 4 in the early feasibility study. And this was unfortunately complicated by infolding of what we had to place was an extension device to extend treatment into the more proximal aorta. Now this infolding, and I'm going to show this to you in the subsequent slide, we were concerned caused a pressure gradient and an endoleak. And actually, if you see this here, what you see is you see the infolding of this particular proximal extension piece on a 1-week CT scan, as well as the endoleak, continued blood flow in the aneurysm sac. Surprisingly, at 1 month, what we noticed was the endoleak actually went away. And this patient had a proximal aortic indication for surgery, but she was, she obviously didn't want it within a week, but when we saw her subsequently, we noticed that the endograft was quite stable, but the ascending aorta had actually increased in size by 58 millimeters. And importantly, we should note that the blood pressure at the time of this 1 month CT scan was actually lower than that seen earlier. After a conversation, this patient elected for medical therapy for multiple reasons. And so we decided to follow her up with a early CT scan. And unfortunately, what ended up happening is she presented on day 113 with sudden death. And the postmortem that was done at that time surprisingly revealed no evidence of aortic dissection and frank rupture along the lesser curvature with a 4 centimeter tear. You can see this on the back wall of the aorta against the pulmonary artery. Here are the arch vessels. Here's the root. And when we open the greater curvature, you see this tear here. And understand that, at least in my experience, the number of times that I've seen pure rupture versus dissection, which then ruptures in the ascending aorta, you can count on less than one hand. So this was a very, very unusual presentation. And what we thought about was, was it that infolding that contributed to it? And so we went to the computational lab with our colleagues, and they designed 3 models. One, which was a pre-TVAR model, another that was a post-TVAR model, which actually had some infolding. And then the last was an uncomplicated virtual endograft deployment without the infolding. And naturally, because of how the stent graft behaves versus what a native aorta behaves, we had to make the TVAR segment a bit stiffer than the native aorta based on the available data. So when we combine CFD and vascular deformation mapping, and we examined pressure, what we noticed is that the pressure in the ascending aorta, particularly the pulse pressure, increased. You can see it went from 49 to the other 2 configurations, one post-TVAR and one the uncomplicated version, a pulse pressure that went from 49 to the mid-60s. When we looked at wall stress, we found that the flow actually increased the stress against the greater curvature. You can see these heat maps, so post-TVAR versus virtual uncomplicated deployment. Along the greater curvature, there's an increase in flow, but importantly, the recirculation pattern suggested that there was also an increase in stress along the very site that ruptured. And when we combine this with vascular deformation mapping and evaluated strain, what we measured is the strain, or the change in dimension from peak systole to end diastole. And we calculated that Jacobian value, that factor by which the shape changes, normalized it to the blood pressure, because the blood pressures were different. And we found that along the lesser curvature of the aorta, in exactly the site where the rupture occurred, that there was a very large change in the deformation. And our conclusion at that point, you can see my 3 kids here, a little bit younger, was that the stiff endograft actually affected the proximal aortic aneurysm. By increasing the pulse pressure, the infolding really did not affect the wall stress-strain relationships, and that the deformation in the region of rupture increased by almost 175%. So why do we care about all this? It's simple, because I think the healthy aorta really facilitates ventricular ejection and efficient perfusion of end organs. And when we do things in clinic, as we'll do today, we don't really make detailed analyses of blood flow in clinical practice. This is a picture off the deck of the house that we sit there and contemplate life up north. And really what we do is we perform therapy for the disease that we see, but we don't really understand its implications. So we don't do what Einstein did, which is Gedenken, or these thought experiments when we're sitting there taking care of patients. We treat patients a little bit differently. And so perhaps this approach of routine aortic repair to treat one problem makes another problem. Remember those unknown factors in this inequality on the right. So I want to highlight perhaps what is an unrecognized problem that was, really pointed out by my colleagues who I work with. And this has gotten a little bit of traction in aortic surgery now. People are looking at this because of the work that they were able to accomplish. So we took 8 patients who had descending thoracic aortic aneurysms. They were all treated with thoracic endografts, as you can see here. And in this group of 8 patients, we had CT angiograms pre and at 1 year post thoracic endovascular repair. Importantly, we also had echoes in these patients as well. And the finding that we had was that there was an increase in left ventricular mass over the course of that first postoperative year. 26% by echocardiogram, 15%, as you can see, by CT scan. And I think to understand this, one needs to remember the underlying basis of the circulation. So our heart operates within the parameters set by what's called the end systolic pressure-volume relationship and the end diastolic pressure-volume relationship. There is a part that the heart essentially functions from end diastole here all the way to end systole and back around in this loop called the pressure-volume loop, where it does useful work. The area within this curve is what's called the potential energy or wasted energy. And when we combine this with afterload as determined by what's called the arterial elastance, and we note that the ratio of the contractility and the afterload is 1, this really defines what optimal stroke work is. And when we applied this in this particular scenario, we had to actually get the CT scan, do fine element meshes with it, do what's called develop 3-element Windkessels for the outflow vessels. And we used the echocardiogram derived inflow, the cardiac output, tuned it to the blood pressure cuff measurements that we got. And we developed these models. And ultimately what we were able to do was develop elastance functions, or these PV loops, pre and post TVAR. And the remarkable thing that we were able to find computationally is that there was a marked increase in the left ventricular stroke work. You can see these gray loops are much bigger in area than the red loops for each of these 8 patients, to the tune of 26%. So why did this really occur? It's because of this critical function called the Windkessel effect that the aorta actually serves. We don't think about it in clinical practice, but it's actually a very important thing. So what the aorta does, partly because we've got these bouncy glycosaminoglycans sitting within the wall of the aorta as shock absorbers, is that when a volume element of blood is ejected from the heart into the aorta expands more prominently in the ascending component, by the way. And then it acts as a shock absorber. And then in diastole, it recoils to maintain forward flow. And when we do replacements of the aorta, what it really does is it increases the afterload by elimination of this Windkessel function, something that we don't think about when we perform this operation and the long-term consequences of this probability. Now, to understand what this really means, one only needs to go back to when I was a medical student and I was told isolated systolic hypertension is not an important thing. We see that as people get older. And what we found in the 33 years since I graduated from medical school is really it does. Because if you develop isolated systolic hypertension, which is partly because we lose this Windkessel function as we age and we lose elastin, what happens is our risk of heart failure actually goes up. And so I suspect that when we see these patients, we have to think about something else that actually could serve in understanding the probability of this complication. So I think in answering the what I can tell you is CFD, computational fluid dynamics, and vascular deformation mapping are really very powerful tools to better understand the impact of what we do and understand this better. This is in Barcelona. We were, or I think Valencia actually. We were enjoying a nice plate of paella. So I think the next question is how we go about doing it. And I think before people fall off, I think I fell off the rocker. I just asked for people to listen to the whole thing and then make the judgment. So I believe there's 5 stepwise principles, one really for each finger. And the step 1 is what I term the Heisenberg uncertainty principle. So this is a fundamental principle in all of physics. And since it was postulated nearly 100 years ago, has not been proven to be incorrect. And what it says is that the position and the momentum of anything, we will never know the complete truth. So there is always an inherent error, even though it's small. This Planck's constant is 10 to the minus 34th, really tiny, but we will never know the position and the momentum of anything. And really what it has been thought to relate to for decades is that when you make an observation, what you do is you perturb the system a little bit. So think about this electron you're trying to find out where it is. You shine a beam of light, a photon comes in there, hits it, the electron will move. And so by the time it gets back to your eyeball or the microscope, it's moved along its path. So philosophically, what I think this tells us is that we will really never know the real truth, that we're constantly searching for. And that in order to know one thing better, meaning if we want to make this an equal sign, not an inequality, we have to steal from the other. So if, in order to know the position, we have to steal a little bit from the momentum. And I think this brings us to the really principle in step one, and that is that really to minimize error and to find the truth, we must do it most gently. The only way is by asking why. The second is the Albert principle. Look at Albert Einstein. In 1905, in March, he discovered the photoelectric effect, for which he won the Nobel Prize. In April, he extended understanding of Brownian motion. In May, he had special relativity, and in June, E equals mc squared. It's a pretty good spring. About 10 years later, he developed general relativity, the theory about the curvature of space and time. And if you look at it, what Albert Einstein was able to do was really think about things on the smallest of scales, and yet think about things on the most grandest of scales, as you can see with general relativity. And I think that leads us to principle number two, which I think we need to apply if we're struggling at principle number one. And that is, we think in the weeds, but we see the farthest possible distance ahead. The third is really, if we're struggling, we then go to partners. And the way I look at partners is, I think that they're symbiotic, not the ones that are parasitic. And we don't need to be equal in everything when you're a partner. But really, it's about who you find symbiosis with. It's those people that'll push the ball a little bit farther down for you to sit there and reach for. It's those people, when you fall, they will come and help you up. And those partners who may share those beliefs, those inherent beliefs, and for me, it was very easy, those of integrity, that of loyalty, and importantly, that of initiative to get better. I think the last, the fourth step is really what I term the Phoenix principle, and one to think about is, the way to think about it is growing grass in Phoenix and Scottsdale really worth it? You know, it could be recently renamed the Matthew Stafford principle, as you can see here, as the man struggled a little bit in Detroit, but in LA found the Super Bowl that he was seeking. So sometimes, you know, the patch of grass is not the best patch, and perhaps when you're in your research endeavors, you're thinking about it, you know, it needs to be a little bit different location. And then the last principle, which I'm going to go through, I'm going to give you a little bit of understanding about two people. So Juan Perotti, in September 1990, described the first endovascular repair of thoracic or abdominal aortic aneurysm. And interestingly, this paper was rejected by virtually every single paper. It got published in the first journal of the Annals of Vascular Surgery. I think it's probably the highest paper that's been published in this particular journal. And you can see this thing here. So just a seminal contribution that was rejected by so many people. Einstein, our big friend in physics, had the same sort of phenomenon. In 1900, he graduated from college with the Zurich Polytechnic with a teaching diploma. There were no teaching jobs. And in 1902, he had to go work as a Swiss patent clerk. Well, in 1905, he had a really good spring. And then a month later, somebody thought it was a good idea to grant him a PhD. And then it was only 3 years later that the man got his first teaching job. And I think came up with the statement, probably because of this: you will never fail at anything until you stop trying. Just pick 199, a famous Michigan alumnus. But I think this is the most important principle. And so, you know, in order to understand this, one has to see this from the view of my parents, who, as they moved here at the age of 40, had spent half their life in colonial Kenya, and then the other half of their life seeing how things evolved in the country right next door in Uganda, where Idi Amin was, and then noticing what happened in South Africa. And you had two very different leaders. There was Idi Amin, who basically thought that, if you didn't speak the language that you spoke with, he'd chop off your head to the tune of 500,000 people. Or if you had the skin color that I did, he booted you out of the country, even though you may have been there for 100 years. And so he was a very different kind of a leader than Nelson Mandela. And Nelson Mandela, when he came out of prison, basically said, this country is for everybody. So I think the most important principle is the thing that I heard, my brother heard in our house every day, which is that at some point, everybody is going to treat you like a second-class citizen. People are going to treat you like a second-class citizen. And that doesn't matter, because the most important thing that you have to do, and this is them talking to me, was you have to actually put your best foot forward and be better tomorrow than you are today. And it's what I call the U principle. It's not step 5, it's actually steps 1 through 5. And as you go about your research endeavors, this is my suggestion. So let's summarize the how. So yeah, Heisenberg, Albert, partnership, Phoenix, and you, which obviously spells happy. So I think the last point is, what is the why, and the singular reason for why this is important. So I've had the privilege of working with our colleagues in the Netherlands for a better part of a decade. And usually the best part is kind of graduation. What we do is we end up the day, we get in the day before, there's a nice dinner that we all kind of get together and trade stories. And the next morning when we wake up, we end up going to the site where graduation will be. And invariably, what we'll do is we'll walk through down the city center, the old center of Utrecht, and we'll pass by this line that's on the ground. And it's the line that Frans Mol, who's the senior member of this, the group, the professor who really started this thing, will point out to our Italian buddy, Santi Tremarchi, that this line represents the northern extent of the Roman Empire. So we got to be a little bit careful about who can cross it. And then what we do is we walk to the academic building, and we have a nice fancy ceremony after we get these little suits on. And in the evening, it's not, we end up having a nice dinner where we get to meet the parents and the family members of the candidate who's graduating. And oftentimes there's a little bit of a roast, that will come with this particular scenario, in this setting, a parody on a Rembrandt painting. So I think it boils down to what is the why, and it's pretty simple. And I'll share with you. Last week on Friday we had our graduation for the Ignace who graduated just over a year ago, and the last person who left us was Yunus. Peter's with us; he'll be leaving us in March. But Yunus left, and I realized at that point the why. And it boils down to this. So Yunus, when he was born in Somalia and ended up going to the Netherlands, obviously because of political issues for him and his family. But really what this signaled to me, and when he came to the United States, he came with a very firm understanding. He wanted to be a cardiac surgeon. He actually had a project. He had the initiative to develop a project that, despite COVID, Alberto, Nick, others, Mike Thompson, who's been part of this now for some time, we were able to get a project together that he presented and was the Young Investigator, received the Young Investigator Award. But what it really highlighted to me was that the reason we do this is because education is the single greatest liberator that we have. That no matter where we're born, that this is the one way that we can sit there and actually make a difference in the lives of everybody. Just ask Yunus and ask people in my family. And I think what it does is it really is the purpose of what we call leadership, and that is to provide opportunity. So here's the other purpose. So I will tell you that, as we jumped on this call, before I put the slides up, I looked at the participant list. And I think I've had the incredible privilege of working with virtually everybody here. And the one thing that I do want to say is I want to say thank you. Because at the time when this pandemic started, the one thing that I noticed was that there were a lot of people who, despite the uncertainties that we're seeing with the pandemic, the virus, people banded together as a team, like a team that I've never seen before. And what I saw was I saw the reason why the professor, the president, mentioned that this was the greatest university, and it was for people that are on this call. So I want to say thank you. But we always get an A-, we never get an A. And I think what we have to remember is Anthony Bourdain's quote, which is that if I'm an advocate for anything, it's to move. It's to move as far as you can, as much as you can, across the ocean, or simply across the river. Walk in someone else's shoes, or at least eat their food. It's a plus for everybody. So I'll just share with you, in 2019 Thanksgiving, there were many of us that have cut turkeys. I was not one of them. So we used to eat lamb korma, pilaf, or all these other things. But in 2019, on Thanksgiving, it was the second year we decided to have a turkey at our house. And this is Zingerman's turkey. So I invited 2 other Africans over. We have the Egyptian African, Ashraf, the Somali African, Yunus, and the Kenyan African, me. And we put up a YouTube video of how to cut this turkey. Now, the thing looked terrible when we were done with it. But honestly, it tasted great. And, if we can eat American food, I think we can all do what Anthony Bourdain is really charging us to do. So I think with that, I'm going to sign off here. This is a picture from up north, and at the place where the lighthouse is on Old Mission. So I thank you. If there's any time for questions, I'm happy to answer them.